Good afternoon, everyone. So it's 1:30, and I think we are clashing with lunchtime, so I'm happy we have at least 7-8 people. Since we have to maintain time, we'll get started. The flow is going to be so. I will just give a small introduction and an overview of DMEK, and we'll cover a few things about donor preparation. Then Dr. Siddharthan will tell us about how to unfold the donor, which is sometimes a little bit of a challenge in DMEK. And then we're going to talk about DMEK complications, some tough situations in DMEK, and we are lucky that we have Dr. Christopher Liu from UK here, and he's going to give us the keynote address dealing with upside down DMEKs. I think we'll keep your talk in the later part so that we'll have a little more audience and people would want to hear you. And we have 90 minutes for our session, so let's try and stick to time. We've had a couple of our faculty dropping out because of health reasons, so Dr. Fogla has been replaced by Dr. Samar Basak, who will be giving his talk, and Dr. Jagdish Reddy's talk is kind of completely eliminated, so we have given all the speakers 5 minutes more than they were originally allotted. So hopefully we should have time for discussion in the end. So we'll get started. Can I have the slides, please? Yeah. So I'm Dr. Rishi Swarup. I'm from Hyderabad, and my co-instructors, Dr. Fogla couldn't make it. Dr. Samar Basak will be filling in for him. He's from Hyderabad. Dr. Samar Basak is from Calcutta. Dr. Ashish Nagpal from Ahmedabad, and Dr. Siddharthan. We also have Dr. Christopher Liu, who will be giving us the keynote address from UK. Like I said, we'll start with an overview of DMEK and then some points about donor preparation and insertion, followed by a talk on how to unfold and ensuring it's the right way up, some complications, some simple ones and some dreadful ones, and then some tough situations from the expert. Then we'll have the keynote address followed by a panel discussion. So endothelial keratoplasty has been evolving. It's gone through PLK, DLEK, DSEK, DSAEK, DMEK and PDEK are now what people are doing. We'll be talking about DMEK in this particular course. So what are the reasons why one shouldn't be doing DMEK? It's a difficult surgery. Is there a pointer? It's difficult to learn, and it takes longer time, especially in the initial stages. So if you're a person whose surgical time is of paramount importance and you need to finish in a hurry, you'll always try to defer doing a DMEK. If you have an option to do a DSEK, you'll try to do DSEK. So that's what happens to all surgeons who move from DSEK to DMEK. DSEK is so quick, and once you've gone through the learning curve, it really doesn't take more than 10 minutes. So DMEK does take time, especially if you have a little bit of a problem. Then in a country like India, we always have a paucity of good quality donor tissue, and that's always a challenge, especially if you're not in an institution which has an eye bank attached to it, so you don't have a backup tissue, so you have all those issues. One funny thing about DMEK is you can't use the best tissues for DMEK. The ones which are really young are a little difficult to use unless you're a very experienced surgeon. Especially for the novice surgeon, it's not recommended to use a tissue that's less than 45 years. So the ones that have the best counts are funnily contraindicated for DMEK. And then you have, because it's a difficult procedure with higher complication rate, sometimes you need to do repeat procedures, especially rebubbling is very common. And sometimes in private practice especially, it's difficult to explain to the patient you need to go into the OR once more, because the patients are very demanding, and so we tend to kind of avoid doing a procedure where you need to do another procedure. The counterpoint is you can actually tell the patient that it's a two-step procedure, and that way the patients are quite okay with it if you tell them in advance. And of course the complications, they are feared. I think all corneal surgeons would agree that this is one of the difficult surgeries. Manual DALC was one surgery that needed a lot of skill, and maybe this is the other one. So that's another thing why people tend not to do DMEK. there have been some publications showing the learning curve, and generally the learning curve may take up to about 50 cases for a skilled surgeon, and for non-skilled surgeon, of course, it's going to be a lot more. And during the learning curve, you can have up to 8% tissue loss, 20% primary graft failure, and almost 92% rebubbling rate, which is like a very, very high rate. So that's about why you shouldn't be doing DMEK, but why should you be doing DMEK? I think the very compelling reason to be doing DMEK is because the graft rejection is much, much lower, almost 1/5 that of DSEK. It's faster and has a slightly better visual recovery than DSEK. And with time, we have understood how to do the procedure better. There have been some surgical nuances have been understood. We've learned how to tap and unfold the tissue better. So with all those things, the surgery has become a little more repeatable and predictable. And thereby, the outcomes have started getting much, much better. So these are the reasons why one should start doing DMEK. It's important to select the patients carefully. Your donor also has to be selected carefully. Avoid too young donors, like I told you, they sometimes tend to have a very tight scroll, which may not open up easily. Sometimes the descemet membrane may be adherent and may not peel off so easily. Diabetics, they tend to have more of tears of the descemet membrane. So if possible, avoid a diabetic donor. Avoid donors in which the fellow eye DMEK harvesting has had difficulties. Both eyes tend to behave in a similar way. And generally, you want at least a 2,500 count when you're taking a patient for a donor tissue for DMEK. Even selection of the patient is important, especially for the novice surgeon. One of the things that is necessary, especially in Asian eyes, where the iris is quite pigmented, is good visibility. So if you have a stromal scarring or a haze, and you may not be able to see the DM scroll so well, then such cases are not ideal for the beginning. You must have an intact iris and pupil, otherwise your graft can get stuck to the iris, or it can hide behind a large pupil, or the A bubble may not stay in place to keep the DMEK graft in place. So all those things will cause problems. There should be no vitreous in the anterior chamber or synechia ideally, because again these are places where the scroll can go and get adhered. If you have too deep an anterior chamber, it's difficult to give good unfolding of the graft, and also to give good tamponade. Avoid aphakic eyes for a similar reason, and again post-filtering eyes, because you don't get a good unfolding of the graft in these cases, and the eye is generally soft. Unlike other lamellar procedures for DMEK, you do need some specific instruments which make the surgery much more predictable and easier. You have ready-made sets that are available from some companies like Goider and Doc, and even some Indian companies have got very cheap sets that are available. You have specific instruments for the recipient for all steps, right from stripping of the descemet membrane to insertion of the scroll into the eye, to cannulas for opening up the scroll, to cannulas for inflating the anterior chamber with both balanced salt solution and air. So you do need a specific set of instruments for DMEK, not just for the recipient but also for the donor. Again, for donor you have instruments to strip the descemets without causing trauma. You have instruments for marking the anterior surface of the descemet membrane so that you can be sure of the orientation. It's a good idea to use a guarded Trephine, which will only cut the descemet membrane and not the stroma. And of course, a variety of inserters are available for DMEK, made of glass, and also nowadays we have IOL cartridges being used. So we'll just cover some of that as well. So when one is getting started on DMEK, it's important to go for wet lab. You may be able to do many corneal surgeries without really doing a wet lab practice, but this is one surgery which you cannot do without a wet lab practice. So practice, 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 both the recipient steps as well as the donor steps. Important to observe videos and live surgery both online and see an experienced surgeon operating DMEK. Ideally, you should see some complications being managed. And initial few surgeries, it's always a good idea if it can be supervised. Go for the simplest cases first, like fuchs, clear stroma, intact pupil, AC not too deep, and then you can get started. So that's just a quick introduction, and then I'll just give an overview of the DMEK procedure. I'm going to the next talk. Sorry. So I'll just run through the surgeries. The donor preparation, this is partly covering my second talk as well. So basically you need some sort of a Teflon block on which you can keep the conisteral rim. Initially, it's a good idea to mark the limbus so that when you invert the graft, you know the borders of the limbus. Then you invert the graft. It's a good idea to first make an initial trephination of a large diameter. In this case, I'm using a 10 millimeter. One could also just core the peripheral Descemet's membrane to cut it. The idea of this trephination is just to get a peripheral cut from where you can start stripping the Descemet. So you can even use any sharp or semi-sharp instrument to just core all around and then start stripping. It's a good idea to also stain this edge so that you can actually see the cut edge of the Descemet's membrane, and it helps you kind of visualize the Descemet's membrane better. Now you can see the edge, and you can go all around and just lift that edge of the Descemet's membrane with any blunt instrument. In this case, I'm using a Sinskey hook. You have specialized Descemet's elevators that are available also if you want to spend money on those. It's a good idea to go all around and lift this Descemet's up, because when you punch, that Descemet's membrane gets tucked into that groove. So if you don't lift it all around, sometimes it can get stuck. Then you use a non-tooth forceps. In this case, I'm using a curved suture type, but you could use any blunt-tipped instrument with ideally something which has a broad tip, so it can grasp a larger amount of Descemet's membrane without traumatizing it. And you basically you do this stripping under fluid so that the surface tension is reduced, something like the SCUBA technique. And basically, you can use 1 or 2 hands. And you have to basically strip slowly and keep an eye on this line. This should always be straight. If at some point that line is getting kinked, that means there is an adhesion between the Descemet's membrane and the Duas layer. And it's at that point that it can tear. So if you ever see an adhesion, try to go around it. Or maybe go from another area and come to that area in the end. Or you could use a little dissector and kind of gradually try and separate that from the other side. So you can see I'm doing this very tentatively, gradually. As I'm watching this edge, slowly strip. You shouldn't strip the whole thing. About 2/3 is what you need to strip. And once you've stripped about 2/3, you can just make it lie down, and you have to stain this part so that you can identify the stripped from the unstripped area. That's what we're going to be doing. And once you've done that, you put it back, you invert the graft, and I'm sorry, I think I skipped one video. So after you've strained the stripped area, you kind of make a punch in the area where the Descemet's membrane has been stripped off. And this is a small 3 millimeters or 2 millimeters window. You can use your keratoprosthesis, Trephine, or a dermal punch to create this little circular opening. And that basically helps you to get a window to mark the anterior surface like so. So now the graft conisteal button has been inverted, and that punched button has been lifted up, and you can put any asymmetric mark. You have ready-made stamps, or you can just stain a Sinskey hook with gentian violet and put the mark. So it's important to put an asymmetric mark like F, S, or a P, so that you can check the orientation when it's inside the eye. Don't put an O. Yeah. After that, you trephine to 8 mm. Ideally, again, this should not be a full thickness trephination, but a partial thickness, just to cut the Descemet's membrane. And then whatever is left can be stripped off. Once that is done, you stain the scroll for about a minute or 2 with trypan blue, and under fluid you can aspirate it using one of the various injectors. So most of these DMEK injectors or cannulas have a broad end and a narrow end. So while drawing the tissue, you keep the narrow end towards the syringe and draw from the broad end. And once it's inside that injector, you can invert it and then inject with the narrow end facing into the anterior chamber. So that's what you do when you're in the recipient. You just, it's a good idea to have an inferior PI. You can do a YAG peripheral iridotomy preoperatively or intraoperatively. You can create a small iridectomy. Then you strip the desmase membrane. You can do it under air or under a cohesive viscoelastic like so, just like we do for DSEK. It's a good idea to mark 8 mm on the anterior surface and then do this. And then aspirate the viscoelastic. You can do this surgery through a clear incision or a scleral tunnel, whatever you prefer. And then basically you have to shoot your graft in, I'm sorry. You have to gently inject your graft in. It's important at this point when your graft has gone in that you make sure that the eye is soft. Otherwise, when you come out, the graft tends to come out. Also, you have to give some counter pressure to hold the wound as you're removing your DMEK injector. Otherwise, again, the graft can slip out. I'm sure Ashish will show us some of these complications. It's a good idea to suture these wounds, at least initially. And then, of course, you can start all your tapping maneuvers. This is the one place where DMEK is really different from DSEK. We tend to press more when we're doing DSEK, but in DMEK, this is more of a like a drumming kind of a gentle taps. And there's techniques of tapping. I'm sure they'll be covered later, so I won't go into the details of those. And then basically, you try to flatten out the entire graft like so, using various tapping and egress maneuvers. And you can see the mark there. I'm sorry, it's not so well seen on the screen. And then you inject a small air bubble and then you enlarge it. You can see the mark here now, F. So you can see the outline of the graft quite well. It's fairly well-centered graft. And the beauty about DMEK is the way it clears up. Sometimes you can't even make out that a surgery has been done in many of these. So this is an important slide showing the correct orientation. Desmos membrane always tends to scroll with the endothelium out. And this is the way it should be oriented for it to be the correct way. And if it is oriented this way, that means it's the wrong way and we need to invert the graft. So results, the study, I think I'll just move on in interest of time. So important pearls, practice, again I'll say practice, practice, practice. Select your cases properly, select your donor properly, counsel the patients well, tell them it's going to take time and you may need 2 surgeries. And don't give up, keep trying till you succeed. Most successful DMEK surgeons have gone through a phase in which they started, gave up, then restarted, and then they started doing regularly. That's all. So I'll just cover some of the other donor techniques once, and then we'll move on to the other speakers. These are just, so I think donor dissection is as important as the recipient part, and it involves 2 things. One is the preparation of the donor and one is insertion. The preparation can be done in eye banks. Many places, especially in the West, they are doing in eye banks. In India, of course, we are doing them in the operation theatre, mostly just before the surgery. I covered all these instruments that we have to use. So the donor preparation essentially involves 3 steps. One is you have to lift the desmase membrane off the Duas layer. That's trabecular meshwork, not trap meshwork. So you could use the Melly's no-touch technique, which is the originally described technique, in which he basically strips the entire desmase from the trap meshwork centrally throughout, and then transfers the entire sheet onto a contact lens and then refines it. That's one way of doing it. I personally have not found it very repeatable, so I've stopped doing that. Then the SCUBA technique, in which you have a submerged tissue and you use the background glow to kind of visualize the stripped desmase. And air bubble assisted has been tried, and with like a big bubble you can try, but that's more, in that you'll have a pre-desmase layer along with the desmase membrane, so it's something like a PDEC. And people have tried hydro separation along, or with trypan blue, they detach the entire desmase membrane and then Trephine it. You could do a marking for orientation, and that really makes the outcome much better, at least in my hands. and then finally you have to load it in some sort of insertion device through which it has to be finally injected into the eye. The donor insertion is usually push in. Most people are doing that using either a tube or a cartridge or some sort of cannula or a glass pipette, or a pull-through technique where you're using a forceps with or without an anterior chamber maintainer. So this is just an illustration showing the no-touch technique popularized by Meili. So basically, this is the traditional technique in which you are stripping and holding the edge, but in this you're basically stripping from the periphery all throughout the entire Descemet's membrane, and then you're transferring it over a contact lens, and then the contact lens is trephined to appropriate size. So you're not really touching the area which you're really inserting into the eye. SCUBA technique, you are basically using the same chamber in which the tissue has come, and you're using the glow from the microscope. It's important to tilt the microscope a little bit while doing this, and because it's under fluid, the surface tension is reduced and it becomes a lot more safer. And SCUBA stands for submerged cornea using backgrounds away, and background is blurred, so your visibility is much, much better. This is a video I borrowed from Siddharthan in which he's using a homemade DMEK injector using IOL cartridge and a syringe and some silicone tubings, which the normal IV tubings. So here he's using an Alcon cartridge, right? AMO cartridge, yeah. So he's detached the tip and then kind of attached it to the silicone tubing on one end, and the one end is attached to the syringe, and you can just suck it into it. Very, very simple, and it does the job very well. Massimo Bussin has been popularizing the TRIFOLD technique, in which the advantage of this being that the endothelium is in rather than out, and it becomes a lot more possibly safer because your endothelium is not really going to be touching the cannula or the cartridge. And basically you fold the Descemet's membrane like a trifold after putting a drop of viscoelastic, and then you transfer it onto a contact lens like so, and then you put it into a cartridge and essentially pull it into the tip of the cartridge using a forceps like so, and then essentially you plug the other end of the cartridge with a silicone plunger. So this way the endothelium is in because you folded it that way, and after you've plugged this, you just essentially under anterior chamber maintainer with the forceps, you pull it in, and because the orientation is already the endothelium in, it will stay that way, and with a gentle tapping on the cornea, the whole thing unfolds quite predictably. So this is another technique which possibly may be very good and simple. And Tan has been using this hybrid DMEK tissue in which he uses a pre-cut tissue like we used to use for DSEK, and then on that he strips the Descemet's membrane and trephines it, and then using his endoglide, he selectively pulls in only the Descemet's membrane and holds it with a forceps similar to what we saw in the TRIFOLD technique under anterior chamber maintainer. And in his hands, this also gives quite predictable results. Thank you. So now we'll move on to Dr. Siddharthan's talk, which will be about what we do once this scroll is inside the eye.
So, good afternoon. So I'm going to show you the unfolding the Descemet's inside the eye. I think this is the most toughest part in the DMEK, because you can train in the wet lab for removing the DM, but ultimately when you come to the real scenario of unfolding, each eye is very different. So I think I have around 6 to 7 videos only. I don't have any slides. I think you can sit back and just see the techniques, because as Rishi said, I started DMEK in 2013, stopped doing DMEK for about a year or two. Then again I had to redefine many things, and from 2015 I started doing, and now we have done quite more than 500 to 600 cases of DMEK we have done. So we have a little bit of experience in most of the techniques, and what we have felt is that there is no standard technique in DMEK, and that's why there's a lot of problem and people are not doing it. So before we go, we have to understand that a simple animation that the DM always scrolls on itself, exposing the endothelium out. So that's why we have a lot of endothelial cell loss, and that's why most of the surgeons prefer DSAC rather than DMEK. And I just show you a video here. You can see that I'm doing a normal taco here. So when I do a normal taco, the endothelium is inside, just as in DSAC. But you see here, this is the tendency of the DMEK or the DM scroll. See, always it snaps open and it comes to the endothelial side. So this is the normal anatomy, and that's why we have to be very careful when you are unfolding the DM. So the mark, as Rishi said, you can put whatever mark, L, F, S, whatever you want you can do, but always orient yourself to the mark what you do. So I do a simple L mark. So I just want to show you that one is a short horizontal limb and one is vertically longer. So when you put this inside the eye, however you rotate, however it's inside the eye, make sure that the short horizontal rim is always on your right side. Means that wherever you are sitting, it should be on the right side. So why I use a L is because when there is so much of, most of the cases when we do, we have a lot of scarring and all, so it's very difficult to find the entire mark. So sometimes if I'm able to see a small, this in the right side, I feel then that's fine and I go ahead to finish. The DM scroll injection, just one point which I've seen is that if you have a small tunnel, it's very difficult to actually inject it. And here I'll just show you. When I'm trying to inject, it's not going in one because the tunnel is small and the iris is coming and plugging, and most of the saline is coming inside the tube. I see I'm just injecting saline, you can see the DM moving in. So means that there is no much space for the fluid to go in, and every time when you go in, the saline from the AC comes into your tissue and pushes it out and doesn't come out. So widen the section, relax the speculum, make the eye soft, don't keep it very hard. Relax a little bit and you can see that it beautifully goes in. So these are small techniques, because once it gets crushed in the tunnel, a lot of endothelial cell loss will occur. So all these things will go a long way. And also sizing. The DM sizing has to be proper, because most of our Indian eyes, they have a lot of damaged iris splinter. Mostly we do very bad eyes. Fuchs we do a lot, but still when we have a dilated pupil, like means this is around maybe 4 mm, 5 mm. So you have to take about at least 1 mm or at least 1.5 mm more the size of the pupils. For example, this is almost a 6 mm pupil. So I have taken an 8 mm graft, and you can see that the periphery of the DM, which is larger, you can see that that portion hinges onto the iris, and that allows you to open. If I have taken a 7 mm graft, it would have gone always stuck inside the pupillary border or onto the IOL. So you have to take at least 1 or 1.5 mm more than what you see of a pupil. So these are important points. As I told you, tunnel size and the DM size, you have to be very careful. So these early cases when we had a lot of problems, so this is a young donor tissue. So when you inject a young donor tissue, look at the scroll. It's very difficult. Whatever methods you use, it's very difficult. Here again, a lot of problems. Once the scroll is oversized, it's already an anteriorly vitrectomized eye. So a lot of problems here. So here unfolding is going to be very difficult. You can unfold this, but finally in about a month or two you will have the graft failed, because it's very difficult to unfold. So case selection is very, very important. Don't take a very young tissue, 30 and all. Size your graft. See whether your eye is anterior vitrectomized. If it is vitrectomized, go for an older eye. Don't go for younger eye. So these are the things which I have learned in the past years. So just wanted to share this. So coming to the unfolding techniques, these are some unfolding techniques which has evolved, and finally I'll be showing what I have been doing, some edited videos of 6-7 videos of unedited. You will be able to see what happens. So here, always after you inject, put a suture. Even if it is unfolded, do not do any manipulation without a suture, because it will definitely come out. If you're doing a scleral tunnel, you don't need a suture, but if you're doing a corneal tunnel, you have to do a suture. So once it's unfolded here, I'm just injecting saline. The concept of shallowing the anterior chamber is now what we have to do. So I've shallowed the anterior chamber, given little bit air and just little bit tapping to position it, and just see, I'm just injecting saline and shallowing it, injecting saline, tapping a little bit. And you can see that it beautifully unfolds, because the anterior chamber is shallow and iris allows you to unfold it very well. So this is one technique of doing it, and most of the times tapping, I don't do any tapping nowadays, because as you tap you have a lot of endothelial cell loss. So this is one technique. Second, always when I inject, because usually it's vertical when I inject, I always try to make it horizontal, because the tunnel, when the tunnel, the saline comes out through the tunnel, it's easy to open. So I shallowed it. With by both my hands I try to slowly niggle it out, and it opens. So this is also one technique which you can do, and you can see that very gentle taps. I am not doing very fast taps, it's a very gentle tap. See, just gently you can move it and it will move, and the AC has to be shallow, and little bit saline has to be there, it cannot be completely shallow. So this is another technique. So nowadays what I do is this technique, see what you can do is here, I am again doing the same thing, trying to inject saline, and I am trying to rotate it, and then I am trying to tap it like how I did before, but it doesn't open always. It doesn't open always. So what do you do? So here the simplest technique what we have evolved is hold with your left hand, inject saline, shallow it, inject saline, shallow it, inject saline, shallow it, and it opens. So no more all rapid tappings, all vigorous tappings, and you can see that very gently you have to handle the tissue. And see that positioning is very important. I usually position it very well. I see to that I position it. It is easy to position, and then the air goes in. Okay. So this is the technique which now we currently do. See, hold it. So once you inject, position it horizontally, move it to the desired position, and then I shallow it. I'll be showing you unedited videos, so it'll be easy to see. You might think all these are edited videos. So this one was an IOL explantation iris claw. So mostly very bad cases where the you have an aphakic cases, or you have anterior chamber IOL, or you have all these problems. Better to go for a posterior iris claw and then a DMEK, because the iris shifts the anterior diaphragm front and it makes your anterior chamber shallow. That's what we want. Then an SF IOL, scleral fixed IOL, all makes the AC very deep, and the iris goes behind. It's very difficult. And placing an iris claw also is pretty easy than doing all these scleral fixed IOLs. It's very complicated, and you have quite a number of vitreous loss also in all these cases. I'll just forward it. I'm just putting enclaving the iris claw, and then injecting, and then I put a suture also. So 3 sutures. So here I just wanted to show you how I unscroll a reversal. So with the left hand I'm just opening, because a big tunnel it can come out. With left hand I'm just holding the tissue and just trying to open it with saline, and I see the L is on the wrong side. So now what do I do? It's on the wrong side. So now see, I'm injecting the saline under the flap. See, I'm injecting the saline for the flap below. You see that the inner flap is slowly scrolling in the opposite side, and see it just comes out. So you have to inject saline in the fold which is down, not on the upper scroll. Just make the scroll a little bit down like that, inject saline so that it just goes in. So that is very important. And I'll be showing one more reversal. So here also. So the L is actually on the wrong side. Once I am actually, it's visible here, but in the scope sometimes it's difficult, and you can see that I've still not yet realized, but see that L is, the smaller portion is here. So now I'm injecting saline. As I told you, inject saline here. So as you inject saline, see it goes and reverses there. So do not do anything without knowing. You have to see that the inner flap folds, and then once it folds, you can hold with your left hand and you can unfold it. So very simple, just position it. So the positioning only, you need gentle taps to position it. Once it comes to a position, just hold it, inject saline, release, and that's it. So it's not going to be very difficult. So now I'll be showing a few videos. These are all unedited videos. You can actually note the time. It's around 38 minutes when I take the scroll in. Sometimes I don't really believe in positioning it in whichever position. I just don't do all these manipulations, because the more you touch, more you pull, more you do, all endothelial damage happens. So whichever position you want, it just goes in, and usually, as I told you, always endothelium is out unless you do a trifold and you do all these things. So this is actually an anterior iris claw I removed in a like an aphakic I removed. So I did a scleral tunnel. So here also see, I'm positioning it, and it just opens. And this was actually a 40-year-old tissue. Because it shallows, it usually comes out. I think Dr. Samar Basak does a lot of scleral tunnels. I think you can see that very nicely it unfolds. And see that at 43 minutes, 4 minutes, it's unfolded fully. So these are techniques which this is an unedited video. So I'll be showing another 4-5 where I have not edited it. Again here, see, it is scrolled. After I put a suture, I'm just showing this. You see 24 minutes. And now, again the same concept. You don't need to tap too much. Be very gentle. Just shallow the anterior chamber. Open it up. See which side you are in. Shallow it. Okay, just gently, just see whether it's on the correct side. Inject. Position it, try to position it horizontally. First you have to little bit open it up, then only you will be able to see which side it is. Once you are sure it's on the correct side, then it's just that you have to place it into a position and then unfold it. So all those days of severe tapping and all these things have gone now, and it's very simple. Make it horizontal, hold with your left hand. Once you know it's on the right side, it unfolds. So I was showing you the video when it was 24 minutes, it's 25 minutes. That's it. It's still hardly 1 minute. And now you can see that once it's horizontal, try to make it it's vertical, try to make it horizontal after injection, and then shallow, and you have to give saline. You should not make it completely shallow because you need a little bit of space for it to unfold. So a little bit of hold with your left hand, and then a little bit of maneuvering with your right eye, injection of saline, shallowing, and it opens. It's hardly about a minute or two. It doesn't take more than that when you follow this technique. And see that here. This I was trying to show you that sometimes it gets stuck up and it doesn't unfold. So here I am trying 2-3 times for it to unfold. It's not unfolding. So since it is almost 75% unfolded, now you can use air. You can use air and then to fill, and then you have to reduce the air much beyond the fold. You can see I'm just injecting saline, releasing air. So once that is done, you can see that that fold is gone. The air removes it within seconds. So this is also one technique. Once you feel that it's not opening, you can put air and also you can try to open it. And in regrafts, the main concept here in regraft is take a smaller sized graft. Don't take large than the graft host junction. Take slightly a smaller graft. Maybe if it's 8, take 7.75 or 7.5 so that it is staying much within the graft host junction, because if it goes beyond the graft host junction, a wrinkle will appear and it will not be possible for you to unfold it. So these are all some of the videos here also. So all unedited videos. I have not edited it. Again the same thing, position it and it opens. So the concept of tapping and all is gone, and now you can predict, you can do the entire procedure. The entire procedure, DM stripping, everything takes around totally 25 minutes for you to do the surgery, because the unfolding is the most important thing which you have to take into account. Again the same, all are unedited videos. So because of want of time, so it's all the same thing. The last one I'm showing the same way. Position it to the size what you want. You just hold with your left hand. Inject saline, shallow it. Inject saline, shallow it. Inject saline, shallow it. And you can see that very well it unfolds in a minute or two. So be gentle, and that's it. Thank you.
Thank you, Siddharthan. That was a beautiful talk, and you gave some really nice tips. I'm waiting to go and try this. I noticed that you're using the main wound for most of your manipulations and not side ports.
I'm not using at all nowadays. That's two side port. I'm put the side port, but I'm not using at all nowadays.
Very interesting. Thank you. This just goes to show there's so many ways to do the same thing, and no one way is correct.
So many techniques will evolve, and you learn your own technique,
Yes.
which may not be reproducible by other
Every
person.
DMEK course, I think there's something to learn, something new to learn. So I think I learned something new now. We'll move on to the next talk. This is our star speaker, Professor Christopher Liu. He needs no introduction. He's one of the pioneers in ocular surface, and he does a lot of DMEK also. And I've had a privilege of listening to him earlier. He has some beautiful videos to share, and I'm sure he's going to give us some nice tips on how to deal with upside down DMEKs. Welcome, sir. He actually deserves being called sir because he's been knighted. Am I right?
So if I may have my slides. Thank you, Dr. Rishi. I think this talk follows on quite well following Siddharth's talk on management of upside-down DMEK graphs. How do I advance the slides, please? So as you know, DMEK is a partial thickness graft whereby the desmase membrane acts as a carrier for endothelium and it is like replacing like. Correct orientation is really important, and that's already been mentioned, and it really depends on the desmase aspect of the graft facing posterior stroma of the recipient. And as was already shown by Dr. Rishi, that the graft always scrolls with the endothelium on the outside of the scroll. Indications, as you know, Fuchs's endothelial dystrophy, very good results. Bullous keratopathy, less good results because of usually some macular damage. And increasingly, we're also using DMEK to salvage a failed penetrating keratoplasty if the stroma is relatively clear and the shape of the PK or PKP is good. So we're just relining it to make it work. And you heard the tip to use a slightly smaller DMEK graft than the original PK, so it doesn't drape over the graft-host junction internally. Complications, of course, there's graft detachment, and the rates depend on the surgeon's experience. Raised intraocular pressure, with some up to 3% developing secondary glaucoma. There is the possibility of IOL opacification, especially hydrophilic lenses, and especially following repeated rebubbling and raised intraocular pressure. Then we're on to upside-down grafts and other complications, as you can see further on the chart. So obviously this is upside-down grafts is an iatrogenic cause of primary graft failure, the other being prolonged surgery and mishandling of the graft. And this may be noticed intraoperatively and managed immediately, or postoperatively, and I will show you the signs, and then managed subsequently through a second operation. The incidence rates of upside-down DMEK ranges from 0 to 18%, and for sure it is underreported because it can be confused with other causes of primary graft failure, and also surgeons may not wish to report them having caused upside-down DMEK grafts. And currently there's no clear guidelines on the technique and time frame of its management. It does provide an exceptional challenge for the corneal surgeon once it has happened. The measures to avoid disorientation we have already heard about. You can mark with an F or an S or an L with a long and short arm. You've heard about that. You can use intraoperative anterior segment OCT, but that's not available for everybody. It is quite expensive. And also you can use the Mutsuri sign, which I will tell you about here. You can see on this diagram that if you put your cannula inside the scroll, then the silvery cannula becomes blue. Whereas if you're above the graft, then it still appears silver. However, this can fool you, so I can show you in a moment how this can give you a false Mutsuri sign. There are pros and cons of graft marking. I mean, it does add time and the ink may smudge. There's the risk of the graft tearing if you use a peripheral mark, either an arrow or 3 asymmetric marks. And if you are to punch and in order to use an S or F stamp, you're damaging the stroma as well, and there will be wastage of material because the stroma itself can be used for a dowel. If you just use peripheral marking, then it can be not visible if the graft is slightly hidden underneath the peripheral cornea of the recipient, which can be a little cloudy. So here I want to show you in slow motion a false Matsuri sign, whereby this actually is upside down. However, we are under the graft and we are manually opening it, but we've opened it upside down. Now the trick is, when you enter to the inside of the scroll, before you're underneath the flap, the silvery cannulae should remain silver. So that's how not to be fooled. Now here's a bit of a messy video. These are when we go back and look at our grafts which were placed upside down. So here again, with lots of air bubbles, which are a bit confusing, trying to open the graft, thinking that it's in the correct orientation and that the air bubbles are anterior to the graft, trying to open it. And then it wouldn't do that because, of course, it's actually upside down, and then going in with a cannula and fooled by a false Matsuri sign. So what happens then once you have created an upside down DMEK graft? Well, it may not attach, and it may detach altogether. It may partially detach, and then when you look at the periphery, instead of the scroll going up like this, it may be going down like that, in which case you know it's upside down. There may be persistent corneal edema, and it's really important to video all your surgery, because you can always go back and look and see. So if you review the surgical video and collate that with the anterior segment of corneal OCT findings, then you can confirm the diagnosis, and then you have to decide, what am I going to do? Am I going to use the same graft and turn it upside down? Or am I going to just take the graft out and put a new one in? The advantages of reorientation: it's more economical use of donor tissue. Theoretically, it reduces exposure of further corneal antigens to the recipient, and theoretically it diminishes the risk of introduction of infection from a further donor source. Also, if reorientation doesn't work, then you can always do a new DMEK. But of course, that would mean a third procedure rather than concluding the matter with a second procedure. And we've already heard, especially in private practice, patients don't really like this sort of thing. So if you're going to reorientate, then you stain the graft within the AAC intraocularly. Also, if it's already detached, you can actually explant it, stain it, and reinsert it. But note that there will be a risk of endothelial cell loss with this particular option. So timing. Timely intervention will be crucial, as there is no evidence as to how long the graft can survive in the upside-down orientation, along with incidence of stromal scarring. So according to studies, viable endothelial cells may remain even after free-floating in the anterior chamber for 2 weeks. However, I would give you a caution that if you rebubble or tamponade with SF6, you can actually make a graft stick upside down, in which case the cells may be heavily damaged. And if you had done that, then maybe it's better to do a repeat DMEK graft. So surgical steps, as we've talked about, trypan blue should be administered into the anterior chamber to stain the primary DMEK, which is upside down. So you'll be staining on the Decimase membrane side. However, if it is detached, if it is attached, so restaining should be done prior to detaching the DMEK graft, so that you don't stain the recipient stroma, causing confusion. And you can attempt to detach the graft by injecting BSS through the side ports. So the remaining part of the talk, I will be concentrating on how to detach a partially attached or fully attached graft. So here we are using jets of BSS to detach an upside down graft. And here we can also use an air bubble to help detach the graft. So firstly, an air bubble. Now, this separates the graft and the recipient stroma, and then it creates space for you to use jets of fluid to displace the rest. And also, you can use the air bubble by brushing it from above to detach the rest of the graft. So just to summarize, if still partially attached, you can create vent incisions as well over the area that is detached. Jets of BSS can be used, and if all attempts fail to detach the graft atraumatically, consider repeat DMEK. This is the final several seconds of video. I would appreciate if you let me show it without the alarm, etc. So here is the bubble, and the vent has been created, and the air bubble was protecting the graft, and you can use that to put jets of fluid in to detach the rest of the graft. Okay, so there you are. We have reviewed all our upside-down DMEKs, and it's being published, and you can see it in a few weeks' time. Thank you.
Professor Liu, could you just share how were your outcomes of these cases? How many of them finally failed? And did you see a lot of endothelial loss when you did the speculars later?
Yeah, okay, so I can't remember the exact details. There were 5 cases altogether, and 3 survived in the medium to long term, and the other 2 didn't and had to have repeats.
Okay.
Thank you.
Thank you. That is a very interesting talk. Thank you, Professor Liu. And we'll move on to another very senior cornea specialist, Dr. Sama Basak. He needs no introduction. And he has vast experience with DMEK, especially in some difficult situations. And I'm sure he's going to share some nice pearls with us.
Thank you, Rishi. Just I'll share a little different concept, what I am working on it. And I'll show little extreme situation. First one, this is a thing I just, I always think about the scroll pattern. So there are maybe 8 types of scroll, part operative. So I'm just playing sound. This video actually,
all about scroll behavior and unfolding.
You see that it doesn't, 65% time, it actually, the scroll listen to us.
Perfect unfolding of the
I mean, I have done already more than 800, and I know that this scroll will listen to me. So a lot of struggle used to go there. You have seen the struggling is too much, reverse, upside down.
unfolding,
But then,
and then we have to struggle again to get it to unfold
Sound.
in the right direction. We know that the S-stamp on the DM side is a savior for the surgeon.
you all know this.
Unfolding time varies between 2 to 17
This
minutes.
is literature says
Even in Fuchs dystrophy cases.
2 to 17 minutes unfolding
In
time.
most of the Western world, the surgeons use eye-bank prepared tissues, but in other places, the surgeon themselves prepare the tissue. Most surgeons use some kind of injector system, mostly IOL cartridge or glass cannula. Donor loading can be done either from the button or it can be done from a petri dish, which gives the advantage of seeing the scroll pattern and then loading the donor according to the scroll orientation. We have classified the different scrolls based on their behavior and orientation as follows. Classical double scroll, a reverse double scroll, a
Look at
tight
the
scroll,
S in between.
then a not so tight scroll, a half scroll, similarly a reverse half scroll, a zigzag scroll, and sometimes there is no scroll. So it is clear from these examples that this knowledge is important for us before donor loading. We use a homemade injector system using IOL cartridge and 2cc syringe. And we prefer loading from the petri dish before injecting into the AC. So what is important is, after observing the scroll pattern in the Petri dish, the donor loading in bevel up or down position, check the orientation of the S mark within the cartridge. Now the AC entry is done in a bevel down position. However, depending on the S mark orientation, we rotate the cartridge bevel up or down before injecting. This is then followed by tapping. Let us see a few examples. So in classical double scroll, the loading is done in bevel up position. So we see that the S is reversed when the bevel is down. So keeping that in mind, we insert in a bevel down position and then rotate the cartridge and then finally inject the scroll. Alternately, we can load the double scroll in a bevel down position. Then there is no need to rotate the cartridge. We can just go in bevel down and inject. And then tap and unfolding is easy.
Normally I don't put any switch.
Similarly, in a reverse double scroll, we load in a bevel up position. So when it's bevel down, the S is oriented in the right direction. So we just go in bevel down position and inject in the same orientation. In tight scroll, it is very difficult to see the S stamp within the cartridge, so that there is no rule to be followed. You can load bevel up or down and then inject in a bevel down position after the AC entry, and using a small burst of BSS, open up the scroll, and things are usually favorable most of the times. Now for a not so tight scroll, then we can clearly see the S mark within the cartridge, and we follow the same principle as before. So depending on whether the S is oriented in the bevel up or down position, we rotate the cartridge before injecting. Here's another example of a similar not so tight scroll. Here the S is correct in the bevel up position, so we go in bevel down, rotate by 180 degrees and then inject. So as you can see, even in difficult situations like presence of a tube shunt, things are not so difficult. In a half scroll or a partial scroll situation, again we can apply the same principles. So in this case, S is right in the bevel down position, so we go in bevel down and we inject bevel down. And just with a few taps, unfolding is complete easily. In a flat or a zigzag scroll situation, so we cannot see the S mark again, so there is no rule to be followed. We can load in the bevel up position, and then the AC entry and injection is done in the bevel down position. The advantage is it opens very easily, and 50% of the times we are right. So the important point to remember is to check the orientation of the S mark within the cartridge, and based on this, before injecting, we rotate the cartridge. Let's watch another different example. The S is right and the bevel to the left side. So we enter bevel down, rotate it by 90 degrees so the bevel is facing the left side, and then we inject in a sideways fashion, and this ensures that the DM is facing the right way. So the lessons we learn from scrolly tails are that look for the S stamp within the cartridge, check whether it is bevel up or down. Then depending on that, before injecting, again rotate to orient the cartridge in the same direction so that once we inject, the DM is on the correct side. So this whole exercise makes unfolding easier, reducing the time to unfold. In our series of over 500 cases, in the last 125 surgeries, the mean unfolding time has been reduced to about 68 seconds. Also, there is very less manipulation of the DM scroll, which equates to less endothelial cell loss and better surgical outcome. Thank you for watching.
So I'll show another, I will have how much time? 5 minutes. 5 minutes. So I'll say one difficult DMEK, I call it extreme DMEK. This is only 4 minutes video. Sound. See the vascularization, amount of vascularization, etc. So phaco cannot be completed in this particular case. So I try to resist the DM fast to see more visibility, but so whole thing anterior chamber phaco. But again the epinucleus was not coming and the visibility was very poor. So I extend the incision and use like manually. Thank you very much.
Thank you. I think there were some wonderful tips there, and all aspiring and practicing DMEK surgeons would have learned something nice from that. I think the point of looking at the S in the cartridge and then putting it that way
But
finally.
only one thing I have also glass delivery system like goiter, and glass it doesn't happen because it's very smooth and it rotates
It keeps
within the
turning
so
around.
what you see maybe just before incision
It will turn around.
you have to turn around, and
Okay.
it turns around within the
As
glass
you're injecting.
cannula itself. So
this
it
works
is-
only
this
for
is
the IOL cartridge.
AR40, this whatever you have kept that, in that I have white, that way white background I am working with, and then just before you see, yes, it is there, you just go in, lateral, right lateral, left lateral, all these things I have practiced, and it gives 60-70% time. I am very fast, within a minute.
Okay. Thank you, sir. We'll move on to the last talk of this
Thank you.
instruction course, which is, of course, the most dreaded one. It's on DMEK complications when the going gets tough by Dr. Ashish Nagpal.
Thank you very much, Rishi, for including me in this course. I think after the Hollywood-style videos, I think it's difficult to follow up. We'll try our best. We have collected some complications. There are many complications. We probably won't be able to cover all of them, but there are so many. So we have collected some of my own, some from our faculty. And I think a lot of things have already been discussed. And I think this is the smooth way of peeling it off, as Rishi had showed. And I think this is another one. So when you start off preparing, this is the first step of preparing your donors. And then this is what, as Rishi had pointing out, that what we should be looking at, that horizontal line over there. And you can see the break over here. So when this happens, then I think the DMEK is in majority of cases over, unless you are going to go ahead with this. So at this point, I would just like to quickly get a tip. Rishi, Steve, what did you do in this case next? Did you do a...
So if you get
you
a
don't-
radial horseshoe tear like this, then you have to basically complete that tear and join it up to the periphery.
Okay.
If it's so peripheral, but if it's in the center, of course, you have to just ignore it and go around from another area and come to that
And then come
part
back and do it.
later. If it's peripheral, you can just join it up.
Okay. All right. So that's one tip that we have. If it's peripheral, that you can do that. This is another a collection of some cases from Dr. Siddharthan himself about the steep learning curve, and this is a self-explanatory. Again, the same things when you're peeling, when you're learning how to peel, and when you're peeling, some tissues behave differently. Not necessarily old patients or young, and then you can just sometimes it's so friable it comes off like that. This is another situation in which sometimes the graft that you're injecting gets stuck in the tunnel, as he pointed out correctly in one of his talks, that you should have a larger tunnel. And again, sometimes it just keeps, the staining also goes away. It's very difficult to visualize the right side up sometimes, and it never behaves. It seems to be misbehaving all the time. This is another situation where the visibility is very poor, and
Graft shoots out.
the other aspect is once you've got the graft, once you have the donor, then you have to load it into your preferred cartridge. We use the glass cartridge, and sometimes it's very easy. It is already formed in a nice scroll, and you just take it. You can take it from the narrow end itself. This is a dog cartridge in which it's easier to take it. But here at this point, you should remember that there should be no air ahead, because you should remove all of the air. Otherwise, once that air goes inside, it can again create issues. So keep that in mind, that do not get even a small air bubble into the cannula, even before taking the graft and afterwards. And then sometimes, I think this is one case which Dr. Basak also had. Some of these tissues, I would wanted to pick the faculty's brains for that. Some of these tissues just do not scroll. In fact, they are always opening up all the time. And whatever you do, struggle, it never seems to come into the cartridge. Some people have suggested using the broad end of it and picking up a forceps and putting it inside. But it just sometimes, some of these scrolls. So I think all scrolls behave a bit differently, and they may not behave the same way exactly. So we had a tough time getting it inside, and it totally refused to do it. And at this point, I would like to add, I got a tip. I had asked this to Siddharthan once a long time back, and he had suggested that you should just, I don't know whether he still does it, that he should just shake it, put some saline, push it in, and then so when it is moving around, then you can just quickly take it inside when it is in a sort of a partial scroll till again it's before it starts opening up again. But it's a quick thing that you need to do in a very quick way. So that's one of the things. And here I've just picked up Dr. David Rootman. Everybody knows him. He has a nice YouTube channel, and there was a brief collection of some of the complications which we all have seen, that sometimes the graft goes outside the anterior chamber. Then you are again trying to put it back into the injector. And at this point you can note the bevel is up. So bevel up is a little risky. You should always try and put the bevel down till you reach a stage of Dr. Basak, and then you can maneuver a little bit from the side or here. But initially I think you should keep the bevel down. And again, see, when the bevel is up, the chances are that it may go up, and you should make sure that the tunnel is large enough. Sometimes it will just come back the same way it went in. And this is purely because of the high pressure inside the anterior chamber. So as Dr. Siddharthan said, you should make sure that check the speculum, make sure there is no pressure on the globe, and try and release some pressure inside the anterior chamber, and then make some maneuvers. Here again, the pressure, it's just not going in, it keeps coming back into the cartridge. The similar situations keep happening, and you can see the pupil is dilating and contracting. And sometimes if you're not careful, the graft may end up behind the iris as well, especially if the pupil is dilated. And then you may have to go and fish it, come out, do it again, and you're causing more trauma to the endothelium. So all of these things do happen initially. So these are pointers that you pick up to keep in mind, that you should have a smaller pupil, choose your case properly. And this is another similar situation in which the tissue immediately just went inside. So try and make sure that you're not pointed in the center, try and point towards the periphery, so that you push it towards the corner first, and then you start manipulating it. Yeah. So this is a straightforward case again, which it went in the right way, and then it was fairly easy to open it up just by tapping it, and then you put an air bubble and you can see the F mark. But sometimes this is not what happens, and sometimes it may form like a crumpled shape inside. And then it's very difficult to figure out which side is up or which side is down, and then you try and tap it and open it up. I'll just move a little ahead in this case. So in this case, once it's opened up, you realize after that it's upside down, and then I think it's already been covered very nicely, that how you can make Siddharthan's tips and Dr. Liu's tips on how to try and make it, turn it over again, is to push in some fluid, and you can use the double tap maneuver to open it. I think I'll move ahead with this part of the talk. And now we have some sometimes again the injector, this is again a glass injector, and while injecting, sometimes if the wound is small, sometimes, or for any other reason as well, sometimes the graft may get stuck in the tunnel itself. I think Rishi, you can add your perspective to it. What happened actually?
In this particular case, I did all the things. I pressed the wound as I was withdrawing the cannula, but in spite of that, it came and got stuck.
Yeah.
I think essentially the anterior chamber was pressurized. So possibly when I felt that it was a little tight, I could have, before withdrawing it, also decompressed the paracentesis and let out some more fluid, and then withdrawn my cannula. That could have prevented the situation.
So I think the problem with DMEK is similar, that if you have a small tunnel, it's a problem. If you have too large a tunnel and pressure, it can come out from the other end of it also. So you need to balance everything very carefully. And because it's all working on a capillary action, it's very responsive, the Desmet's membrane. So it keeps coming out. This is, Dr. Fogla shared this video yesterday to share. I think this is a scary complication. And so I think he had already inserted the graft inside the antechamber, and then there was some oozing which started from the area of the PI, and it gradually went on increasing. I think he did try to clear it up, but it wouldn't stop at all. And I think sometimes when things go wrong, everything seems to go wrong. So this was a constant oozing which is happening, and the graft is inside, so you cannot even put in an anti-air bubble to improve the pressure. So it's a catch-22 situation. So eventually he did remove the graft and put in an air bubble, and then inserted another graft. So this is a lot of blood which will definitely cause problems, but for DMEK,
in the main incision, if you go past the main incision and past the pupil, you won't have this backlash of this. And if you have an anterior chamber is full with pressure, then you can just take a spatula and press on the paracentesis, and then you can inject it more safely and go out while you're injecting it, and then you have a really low chance of the graft coming back to you. And we're not doing any more PIs. I mean, we're using SF6. And we are just checking the patient 2 hours after surgery. And if there is any problem or pupillary block, we just, because of those bleedings that we had, we just take air out of the inferior paracentesis. And as hard as you push, you won't get less than 60 to 50% because the air won't go out from the inferior part. So we will have still 60% of air. So that's it.
Thank you. I think those are some nice tips.
Yeah, I was trying to do the PI-less DMEK, but the patient understanding in our setup didn't allow me to go with this maneuver. Rather, if you do PI, if you are safe, and I always use 100% air, never used any gas, C3F8 or SF6. So patient's understanding is very important about the procedure and positioning of the head after the surgery.
Thank you. I think we had a good instruction course. I'd like to thank all the instructors and the keynote speaker and the audience for being so proactive and participative. We'll just have a quick picture and then we can disperse.